Welcome back and welcome to our symposium, which is titled How I Choose the Best Treatment Strategy for My DVT Patients Using AngioJet, When to Lyse, When Not to Lyse. This session is obviously sponsored by Boston Scientific and we're very grateful for their support. I'm absolutely delighted today to be joined by Stefano Barco from Zurich, who is an expert in treating patients with DVT. And we hope that out of this symposium you can achieve some clear objectives. We would like to make sure that we impart some information on understanding the right patient to treat effectively with AngioJet, and with what approaches you can achieve PTS rates of less than 10%. To learn how to use AngioJet, what the tips and tricks of AngioJet are, and to hear about some of the latest data available for AngioJet use. Before we get into that, we're going to put a poll question up that you can answer while we start the symposium, which is about the treatment of your DVT cases. There's lots of discussion about acute, subacute, and chronic DVT these days. So we want to know from the audience, when you're treating a DVT case based on thrombus age, are the majority of your cases acute, as in less than 14 days, subacute, which is 15 to 30 days, or are you prepared to treat chronic cases which are older than 30 days? This definition is obviously not pure science, but it's a rough guide to when we think chronicity changes. So while that poll is up and you're voting on that, we'll get on with the presentations. Again, remember this is an interactive symposium, so please do submit questions for myself and Stefano. We'll do our best to answer them either live or on the app. We're going to lead off with a presentation for me first, which is achieving best outcomes when treating patients with acute iliofemoral DVT. Lessons we've learned from Clear DVT and other studies. So these are my disclosures for this presentation. Can we advance that slide? So the objective of treating patients with thrombectomy or thrombolysis is to take patients from the picture we see on the left, where acute clot has blocked a vessel and caused symptoms, to something like we see on the picture on the right, where a patient has got a clear open vein, and this is returning to what we'd consider normal, or the open vein hypothesis. And that has driven the majority of the research work we've seen in the last several years. And this is because we know that PTS for patients on anticoagulation alone is going to continue to be a problem. And in all the studies, regardless of the outcome of a comparison against intervention, rates of PTS in patients with iliofemoral DVT remain high, and best medical therapy has not really reduced that. And that includes the more recent studies on DOACs, where although the headline was that apixaban reduced the rate of PTS, in that particular paper, the rate of PTS in the apixaban group was still 60%. It was just so that the warfarin group in that study was even worse. So predictors for PTS are really about residual thrombosis and popliteal vein reflux, and those have come out from multiple studies. And so this lends credibility to the key question, and we saw that from the beautiful talk from Narayanan earlier on, that if you clear all the clot and you get the vein open, we should be able to reduce the incidence of PTS. And we know that they're also predictors for poor outcome after CDT or PCDD, and these really are about the risks for lysis, which are related to bleeding complications, and the indicators for poor outcomes are also related to inability to do a proper technical procedure. In other words, if you leave a lot of residual clot behind, you're going to get a poor outcome. There are several randomized trials now that have looked at treatment of DVT with acute clot removal strategies. Not all of these have used AngioJet. AngioJet was available in ATRACT, but the older AngioJet system, ATRACT used a variety of different techniques. The CAVA study used ECOS exclusively, and the Norwegian studies used CDT, some of that delivered with a power pulse technique. What we know from CAVENT is that the longer you follow these patients up, the bigger the delta between patients treated for acute DVT and clot. And if we review this analysis by putting it into a forest plot, we can see that ultimately the combined weight of evidence tends to favor treatment of patients over non-treatment. And this is based on an improvement in symptoms. It's not based on removal of any risk of PTS or PTS being completely obliterated, but it's based on reduction in symptom burden. And we know that mild PTS is a different beast to significant or severe PTS. Again, the same thing applies to the iliofemoral segment. So there is a greater benefit from early thrombus removal when looking at moderate or severe PTS only, and that is much more dramatic than if you combine that with mild PTS. So the reduction of severity is important. We do understand that early thrombus removal is associated with a higher risk of major bleeding, and we think we've seen that improve over the years as the devices have got better, which has allowed us to reduce the overall dose of lytic or even eliminate it completely, and this is significantly important in reducing bleeding risk. This allowed the ESVS guidelines, which came out in 2022 with the clinical practice guidelines for acute DVT the previous year in 2021, that gave a grade 2A recommendation to clot removal strategies with iliofemoral DVT. This does not apply to femoral DVT, and actually the recommendation was against treating patients with femoral DVT, and this is an area of future research that we certainly need to pursue. So what was our experience with AngioJet? We, as Narayanan indicated in his talk, that's our mainstay of treatment for acute DVT patients in St. Thomas's Hospital. We looked at a comparison of 81 patients who had CDT alone against 70 AngioJet thrombectomy patients, and this was published in the European Journal of Vascular and Endovascular Surgery. And we had really comparable groups between those two patients, matched for all the various risk factors. The groups were not randomized. They were based on availability of devices for sure and time, but the groups were relatively well matched for all the respective features that you may consider. And the safety profile looked really good. In fact, we had only one major bleed in our group of patients, and that occurred in the CDT group, where a patient after 3 hours of lysis had an intracerebral bleed. So this was really early in lysis as well, and turned out to be related to an undiagnosed cerebral malformation that was exposed by the addition of lysis. What we did look for particularly, and we'll get onto this in some of the chat, was the consequences of renal failure and hemoglobinuria that are a particular issue with devices like the AngioJet with cause hemolysis. And we had a reassuringly low rate of renal failure, though we did see an increased rate of hemoglobinuria. It's worth noting that the baseline creatinine for all patients, whether they were CDT or AngioJet, is raised, which suggests that patients presenting with a significant clot burden already have abnormal creatinine to start off with, and it's really important to pay attention to hydration. We saw significant improvement in post-thrombotic syndrome in these patients, and this really stands against the ATRAC data, where the vast majority of our patients had no PTS at all, and very few patients were in the moderate or severe categories. What we also found was that the use of AngioJet early resulted in a reduction of duration and treatment of dose of lytic. So from our data, our really strong recommendation is that AngioJet used upfront with power pulse mode really speeds up the procedure and gives you a better result. This is often used in combination with CDT in our practice, but what it did was reduce the total treatment time down to 24 hours without extension. We've run the CLEAR DVT study, which was again supported by Boston Scientific. This was a study I ran in conjunction with Mitch Silver in Columbus, Ohio. Initially, we had aimed to recruit 70 patients, but our recruitment was really put a stop to by COVID, and we therefore stopped the study early at 35 patients. But these patients have all been now followed out for more than a year, and what we've seen in a cohort of patients treated in 4 centers, where we paid really close attention to detail of how we delivered treatment, we have one patient in the whole study who has mild PTS with a Volta of 5, and the remaining patients all had no PTS. And in addition to that, we had 98% patency of treated segments at 1 year, which points to a significant improvement in technical delivery of the treatment over what we saw in the treatment arm of ATRACT. So what did we learn from all of this? Well, you have to obsess about detail, and we mentioned that earlier on. You have to make sure that your access point is correct. You use IVUS. Narayanan really made a good point about profunda inflow at the end of the last session. You have to focus on getting really good flow from the profunda. And often you'll see a little bit of clot that hangs around in the profunda vein, and if you target that to make sure you clear it, it's vitally important. Get your anticoagulation really tight. We make sure the patients are fully anticoagulated on the table before we finish treatment, and we make sure that they get their first dose of low molecular weight heparin therapeutic dose within an hour of completion of the procedure, and we monitor this with ACT levels before we stop. Hydration to avoid renal impairment is really important. Make sure the patients get fluid. Take all your sheaths out on completion. Don't leave those to be removed when patients go back to the ward. Use stockings and intermittent pneumatic compression. And again, I'll say IVUS twice because I can't overemphasize how much I think IVUS improves the delivery of these treatments. What we know from the data is technical success is crucial. The technical success, in other words, an open vein in the treatment arm of the studies was only 60% in ATRACT. That means that 40% of patients had occluded veins at 1 month following the treatment in the cohort of patients that had duplex. The vast majority of patients weren't even checked after the initial procedure. In CAVA, this was even worse at 50%, while in clear DVT, we had a technical success rate of 98%, and that translates directly into improved patient outcomes. So how you deliver treatment is really, really important. This is our protocol of guidance in St. Thomas's Hospital, which is our treatment pathway for assessing what patients should have intervention and what kind of intervention we're going to deliver. It's a fairly pragmatic look at trying to stratify patients by the age of clot, which is quite difficult to do based on clinical presentation alone, but where we rationalize patients into the use of CDT, pharmacomechanical thrombectomy, or purely mechanical devices, and we've used a range of treatment options to deliver that. So conclusion from me is PMT remains the gold standard for us at the moment. There is clearly a move to mechanical devices, but up till this point, PMT remains the benchmark for treatment. Done well, we have learned that these procedures can be done with a low risk, and the outcomes are much better than were achieved in historical studies with older devices, and that speaks to a movement towards better treatment. Patient selection is clearly crucial, and you have to focus on the detail of treatment to make sure you get good results. So thank you very much. We're going to move on to our next polling question, but we'll just look at the results from the first poll. It seems that the majority of people here are focused on acute thrombus up to 14 days. So very few of our audience are treating patients with subacute, and only a fifth are treating patients with chronic thrombus older than 30 days, which I think really does fit with the sort of patterns that we would see in our own institution. So we'll put up a second poll question, which is, what is your biggest challenge in trying to treat more patients? So all of us have faced the difficulty in developing patient pathways. So if you could give us a favor of where you find the biggest difficulty in getting your patients to treat, is that either you may not have a challenge, some people have very good pathways, getting patients early enough, hospital infrastructure, or cost of these treatments. And while you're voting on that, I'm going to hand over to Stefano, who's going to take us through how he treats a patient presenting with iliofemoral DVT from Rethro on ECOS AngioJet. Stefano.